Hello, it's Dmitry again. Today we'll be going to the part 2 for the endocrinology section of the Mehlman Medical Internal Medicine PDF. So we were ending off on page 359, and we wanted to go into the next, we're going to continue with the chapter, with the section, all the way up to page 375 was where it should end, around that page. So that shouldn't be too crazy. So let's begin with renovascular hypertension. Renal artery stenosis. Narrowing of one or both renal arteries due to the atherosclerosis that causes an elevated inretin angiotensin-aldosterone system, RAS, and elevated blood pressure. The question will be a patient over the age of 50 with the cardiovascular disease risk factors such as diabetes, hypertension, and or smoking. Patients who have pre-existing hypertension causing atherosclerosis leading to RAS, or I should say the renal artery stenosis. Don't confuse RAS as an RAAS with the, versus RAS, RAS, so renin artery stenosis. So a patient will have a pre-existing hypertension causing atherosclerosis leading to renal artery stenosis will often have 10 to 20 years of background hypertension and then becomes accelerated over a few months to 2-year period. What this means is that there's a slowly developing atherosclerosis in the renal arteries and finally reaches a point at which the kidney is unable to maintain autoregulation. And the renal artery stenosis is now clinical. That is to say, accelerated hypertension of significantly elevated blood pressure within, for example, 3 months. Another way USMLE will give renal artery stenosis is by giving an elevated blood pressure in a patient with significant evidence of atherosclerotic disease, for example, a history of coronary artery bypass grafting, intermittent claudication, and then ask you for the most likely cause, which would be renal artery stenosis. You have to say, well, he clearly has atherosclerosis in his coronaries and aortoiliac vessels, so that means he will have it in the renal arteries too. Question can say an older patient with a carotid bruit has a recent significant increase in blood pressure and then ask for diagnosis. The answer would be renal artery stenosis. Similar to above, if the patient has an atherosclerosis in one location, that is to say carotids, then he or she will have it elsewhere too. High-yield factoid by renal artery stenosis is that the ACE inhibitors and ARBs will cause renin and or creatinine to go up. This is high yield because that point is often overlooked and is asked on NBMEs. I have not seen NBME care whether it's uni or bilateral in this case. Kidney can autoregulate across flux in perfusion. Patients with already compromised renal blood flow are more sensitive to the subtle decrease in filtration fraction that occurs secondary to ACE inhibitors or ARB use. So renin/creatinine increase. If USMLE gives you an unilateral renal artery stenosis, renin is only elevated from that kidney. The other kidney will not produce the elevated renin. After renin and aldosterone levels are obtained, the MR angiography of the renal vessels is what the USMLE wants for the next best step in diagnosis. Fibromuscular dysplasia, FMD. The answer on USMLE for narrowing of the renal arteries in a woman who's in her 20s to 40s, not the same as the renal artery stenosis and not caused by atherosclerosis. If you broadly say renal artery stenosis, that specifically refers to atherosclerosis of the renal arteries in patients of greater than 58 years of age with CVD. FMD is tunica media hyperplasia, not dysplasia, despite the name, that results in a string of beads appearance on renal angiogram. MR angiography is the answer on NBME for diagnostic modality. It can affect the carotid vessels. A 2CK surgery question gives the fibromuscular dysplasia vignette and also says that there is a 25% occlusion of one of the carotids. You can see a little image right there for that for FMD. What about polyarteritis nodosa? As discussed in the cardio PDF, this is a medium vessel vasculitis that causes a string of pearls appearance of the renal vessels. This can be confused with FMD, but note that the difference in the imaging. For fibromuscular dysplasia, shows more beading along the larger/proximal arterial sections, whereas the polyarteritis nodosa shows pearls more at the vascular termini, with the more proximal parts more likely to be spared. Angiogram of pan of the polyarteritis nodosa shows pearls that are more distal in the renal vasculature. Firomuscular dysplasia, in contrast, shows more proximal beating with the termini not as conspicuously involved. There is an NBME question where they list both PAN and FMD as answer choices and relies on you knowing the angiogram to get it right. They do not mention hepatitis B, but the answer is PAN. That's why I'm harping on this here. Can cause fibronecrosis, can be caused by hepatitis B, spares the pulmonary vasculature. What about renal artery thrombosis? For renal artery thrombosis, the answer on USMLE for hypertension is a neonate following umbilical artery catheterization. USMLE simply wants elevated renin, elevated aldosterone as an answer. Sounds weird, but you need to know umbilical artery catheterization is a major risk factor for renal artery thrombosis in neonates. 2CK NBME gives a brief umbilical artery catheter insertion in kid born 26 weeks gestation in order to monitor blood pressure for pneumonia. 3 weeks later, he has an elevated BP of 128/86. The answer should be elevated renin, elevated aldosterone as an answer. Now, blood pressure in terms of neonates should be 60 to 40. In a preemie 29 weeks gestation, it should be 50/30. So 60/40 for term neonates, and then 50/30 for the premature. What about primary adrenal differential diagnosis affecting aldosterone? So this is talking about Conn's syndrome at all. So Conn's syndrome, aldosterone secreting tumor, causes elevated sodium, lower potassium, elevated bicarb, and elevated pH. Renin is low due to the negative feedback at the kidney. In other words, the elevated aldosterone from the tumor causes an elevated fluid retention, which causes an elevated renal blood flow, which shuts off the renin production. In 50% of aldosterone derangement questions, sodium will be normal. This confuses students because the body has a strong ability to maintain sodium, that is to say, also via ADH. The treatment would be spironolactone, aldosterone receptor antagonists, prior to surgery. What about familial hyperaldosteronism? There are gene mutations that cause an elevated primary adrenal production of aldosterone. If the USMLE gives you a question where the various family members have an elevated blood pressure plus aldosterone, and they don't tell you any other information, including the renin level, the answer is primarily hyperaldosteronism, not renovascular hypertension, like fibromuscular dysplasia or renal artery stenosis. There is a question on 2CK NBME form where they do this, and the student says, but wait, how are we supposed to know it's primary and not FMD or RAS? And it's because if elevated aldosterone is familial, it's likely due to the gene mutations causing elevated primary production of the zona glomerulosa. Addison's disease. Autoimmune destruction of the adrenal cortex leading to aldosterone, a decrease in aldosterone and a decrease in cortisol. I haven't seen the USMLE ever care about decreased androgens, so the effect is predominantly on the zona glomerulosa and fasciculata, called primary adrenal insufficiency because the adrenal gland itself is underproducing hormones. Addison is idiopathic / can be seen in patients with history of other autoimmune diseases, either in themselves or family members. That is to say, the vignette throws in the side detail that the brother has rheumatoid arthritis, or the sister has IBD, or the patient has a history of thyroiditis. You have a decreased sodium, an elevated potassium, a decreased pH, and a decreased bicarb. Blood pressure will either be low, normal, or low due to both a decrease in aldosterone as well as a decrease in cortisol. I explicate this because students tend to just mention the decrease in the aldosterone as the reason for blood pressure being low, but the effect of the decreased cortisol is the high yield for USMLE. ACTH and alpha MSH are both elevated due to the low cortisol, leading to hyperpigmentation, although I would say that the only mention of this is in 50% of vignettes, which is surprising because it's a pretty telltale sign, but it's probably part of the reason why, because it would be too easy for you to figure out. Patients can present with eosinophilia. This is because the cortisol normally plays a role in helping to sequester eosinophils without the spleen, plus facilitates eosinophil apoptosis, so the decrease of cortisol means that there's an elevation in eosinophils. Don't go chasing stool, ova, and parasites. Questions can give you eosinophils of 15 to 25%, where you're like, what? They should normally be less than 5%. Classic Addison vignette is a patient, young or old, I've seen both, who has ongoing fatigue plus hyperpigmentation, and the answer is just ACTH stimulation test. Exogenous ACTH should be normally cause a robust, significant increase in cortisol from the adrenal fasciculata. In the setting of primary adrenal insufficiency, since the adrenal gland is messed up, giving exogenous ACTH won't do anything of value. A decrease in cortisol causes chronic fatigue syndrome. This is one of the most overlooked details in MDME questions and in real life. Anytime a patient has ongoing chronic fatigue that is unexplained, cortisol levels should be checked. If they are decreased, hydrocortisone will immediately boost the patient. Treatment for Addison, that is to say, for example, fludrocortisone plus or minus hydrocortisone. Fludrocortisone is a mineralocorticoid similar to aldosterone. Hydrocortisone is a glucocorticoid similar to cortisol. Waterhouse-Friderichsen syndrome. Meningococcal septicemia causes bilateral hemorrhagic necrosis of the adrenal glands, resulting in a decline in aldosterone and cortisol. A vignette will be a low BP plus a low sodium plus an elevated potassium plus a low bicarbonate patient with meningococcal infection, for example, meningitis plus non-blanching rash, where the answer would be ACTH stimulation test. So remember that, ACTH stimulation test. Let's see, I'm looking back at the page a little bit more. So ACTH stimulation test is the go-to for Addison's disease. It's also the go-to for Waterhouse-Friderichsen syndrome. Adrenal crisis. Patients who are on chronic glucocorticoids, that is to say prednisone, for autoimmune conditions such as IBD, rheumatoid arthritis, systemic lupus erythematosus, etc., will have a chronically suppressed adrenal gland that is atrophied, since prednisone is a cortisol analog that induces negative feedback and shuts off ACTH production. This means that if these patients encounter a stressor such as surgery, trauma, infection, or thyroid storm, where glucocorticoids normally experience an elevated rate of consumption, they are unable to mount a stress response, that is to say, unable to produce an adequate and acute elevation production of cortisol, so they are prone to acute glucocorticoid deficiency and a precipitous decline in blood pressure. Question will tell you a patient who has lupus treated with a prednisone, specifically SLE, but treated with prednisone, who goes into surgery and gets a significant drop in blood pressure to 80 to 40 plus fluids and pressors don't help. The question will ask the next best step. The answer would be IV hydrocortisone or methylprednisone. What we are doing is replenishing the glucocorticoid. Pressors can refer to norepinephrine, epinephrine, or even desmopressin. Remember that without cortisol or cortisol equivalent, that is, for example, exogenous glucocorticoid, we can't get adequate alpha-1 receptor expression on arterioles. So even if norepinephrine and epinephrine are floating around in normal amounts or given exogenously, they cannot bind to alpha-1 receptors to maintain blood pressure. This concept is referred to as the glucocorticoids are permissive of the effects of catecholamines, where they literally permit norepinephrine and epinephrine to do their job. The question can also tell you the patient is being treated with prednisone for lupus or rheumatoid arthritis experiences an acute thyroiditis. Remember, the autoimmune diseases go together, and it gets serious decline in blood pressure. The answer would be hydrocortisone after fluids. Or patient with autoimmune disease gets an infection plus a significant decrease in blood pressure. The answer would be hydrocortisone after fluids. Cushing's syndrome versus disease. Cushing's syndrome, how the patient looks/presents, can refer to any cause of Cushingoid presentation, i.e. exogenous glucocorticoids, ACTH secreting tumor of the anterior pituitary, cortisol secreting tumor of the adrenal cortex, small cell bronchogenic carcinoma secreting ACTH, so forth. Cushing disease, only ACTH secreting tumor of anterior pituitary. If the patient walks through the door and appears Cushingoid due to an ACTH secreting tumor or of the anterior pituitary, then we would say the patient has Cushing's syndrome caused by Cushing disease. The highest yield findings for Cushingoid appearance on USMLE as per Highest yield findings for Cushingoid appearance on USMLE, as per my observation, are purple striae on the abdomen / stretch marks, osteoporosis, compression fracture of the vertebrae, and avascular necrosis of the femoral head, hip pain. Findings such as buffalo hump, moon facies, central obesity, and peripheral muscle wasting, hypertension, and diabetes type 2 are important and pass level, but you really need to know those 3 bold findings I read above. In peds, Cushing's can present as precocious puberty without all the classic findings. Chronically elevated cortisol can cause hypokalemia, similar to high aldosterone. Sometimes NBME will give you a vignette of Cushing's, plus mentions potassium is 3.0 milliequivalents over liters. Normal range should be 3.5 to 5.0. And you're like, why is it that the potassium is low? Is aldosterone high? No. All glucocorticoids have some degree of mineralocorticoid effect at the kidney, similar to aldosterone. In patients who have a high cortisol that affect longer term can occasionally cause hypokalemia. This detail is particularly important for 2CK vignettes. Dexamethasone suppression test. Dexamethasone is a cortisol analog that is capable of exerting negative feedback at the hypothalamus and anterior pituitary. Given to healthy individuals, the result is suppression of ACTH and cortisol levels. The dexamethasone suppression test is done to determine the etiology of endogenous Cushing syndrome, that is to say, the patient isn't taking exogenous steroids. This is because the patient is taking steroids. Clearly, we know the cause of the Cushing's already. Low-dose dexamethasone will suppress the ACTH and cortisol in healthy patients. It is effectively a yes or no test for Cushing syndrome, where if there's a suppression of cortisol with low-dose dexamethasone, then we can say patient doesn't have Cushing's. If the cortisol does not suppress, then we know that the patient has Cushing's, but we just don't know what causes it yet. High-dose dexamethasone helps us differentiate the disease from the other causes of Cushing syndrome. This is because the only Cushing disease will have suppressed cortisol levels. Only Cushing disease will have suppressed cortisol levels. Therefore, if cortisol goes down with a high dose of dexamethasone, we know that the diagnosis is Cushing disease. If cortisol does not go down, then the decrease with a high dose dexamethasone, we look at ACTH level. If the ACTH is low, we say the only way this is possible is to have an elevated cortisol with a decreased ACTH, as if the diagnosis is an adrenal cortical adenoma of the zona fasciculata secreting cortisol. If the ACTH is elevated, we know that the cause is ectopic ACTH secretion from small cell bronchogenic carcinoma. But the reason we know that the ACTH isn't from the pituitary is because of the high dose dexamethasone didn't suppress the cortisol. Cushing disease, elevated ACTH plus elevated cortisol, suppresses with high dose dexamethasone. If the high dose dexamethasone is given and they ask for arrows for how the ACTH and cortisol will change, the answer is decrease ACTH and decrease cortisol. Small cell lung cancer, elevated ACTH plus elevated cortisol, does not suppress with high dose dexamethasone. If high dose dexamethasone is given and they ask for the arrows for how ACTH and cortisol will change, the answer is no change ACTH, no change cortisol. Adrenal adenoma, low ACTH but high cortisol. It does not suppress with a high dose dexamethasone. Same as with the small cell lung cancer, if the high dose dexamethasone is given and they ask for the arrows for how the ACTH and contrast will change, the answer is no change ACTH, no change cortisol. Exogenous steroids, a decrease in ACTH plus a decrease in cortisol. Oh my gosh. Exogenous steroids, for example prednisone, hydrocortisone, are not the same thing as cortisol. The result is suppression of endogenous cortisol. Students get this wrong all the time. So the result is suppression in the case of exogenous steroids. Miscellaneous. Glucocorticoid psychosis. Glucocorticoids can cause glucocorticoid psychosis, which can present as an overt psychosis delirium-like presentation or even just as a general mood disturbance, i.e. depression. The vignette can give you a Cushing syndrome plus depression or a recent IV methylprednisolone injection plus delirium-like presentation for 28 to 48 hours later. Licorice contains glyceric acid, which leads to an elevation in mineralocorticoid effect at the kidney, that is to say, similar to aldosterone. It can cause hypokalemia in those who drink excessive licorice tea. Okay. Catecholamine secreting tumors. Pheochromocytoma. Catecholamine secreting tumor of the adrenal medulla, derived from neural crest chromaffin cells of the adrenal medulla, occurs in adults, can calcify, causes paroxysmal, comes and goes, elevation in BP, which presents as a periodic palpitations and pounding headaches. Because the hypertension is paroxysmal, the patient can have a blood pressure measured in the office at 120/80, so do not exclude pheochromocytoma in this case. Stressors sitting up on the examination table can trigger the elevation in norepinephrine and epinephrine release from the tumor, where the blood pressure shoots up to 180/100. This is different from the white coat hypertension, where the young patient has a 140/90 measured due to to being slightly nervous. Diagnosed with urinary/serum metanephrines. If positive, then do a CT abdomen. Treatment would be phenoxybenzamine, irreversible alpha-1 blocker. If you give a beta blocker first, this will kill the patient. This is because you will have blocked the beta blockers. The norepinephrine and epinephrine have little to bind to now, except in alpha receptors, mainly alpha-1. So we get significant increase in arteriolar constriction and blood pressure shoots up. This is called unopposed alpha. Some students ask about giving a propranolol after phenoxybenzamine. The answer is yes. In theory, this can be done, but USMLE doesn't assess this. They want straight up alpha blockade. So just bear that in mind. Think about phenoxybenzamine as an answer. Pheochromocytoma can be idiopathic or part of a condition such as MEN2A or MEN-B or NF1. I assume that's MEN2A, MEN2B, and F1. If a patient has medullary thyroid cancer, you must check for pheochromocytoma before doing thyroidectomy. This is because if the patient has a MEN2 and you don't check for pheochromocytoma first, doing surgery will cause an elevation in blood pressure due to the catecholamine release and could kill the patient. So you don't want to accidentally trigger this massive release of all these hormones, these epinephrine, norepinephrine, whatever, the catecholamines. You don't want to have that rapidly drop or be dropped into the circulation because you're messing with that organ. Neuroblastoma, essentially the pediatric pheochromocytoma, NMYC gene, secretes catecholamines, can calcify same as pheochromocytoma in adults, grows in the median midline sympathetic chain, usually intra-abdominal, but can sometimes be in the posterior mediastinum. Sounds odd, but the latter shows up on 2CK form. Causes the elevation in BP and findings such as the opsoclonus myoclonus syndrome, dancing eyes, and violaceous eyelids. Sounds like heliotrope and rash of dermatomyositis, but unrelated. Diagnosed with urinary homovanillic acid, HVA, and vanillomandelic acid, VMA, which are metabolites of catecholamines. Meta-iota benzyl guanide scan can be done after HVA and VMA detected. And I'll take a brief break. Just skip ahead if you're watching a recording. Let us continue. Congenital adrenal hyperplasia. Autosomal recessive. 21, 11, and 17 hydroxylase deficiencies. 21 hydroxylase deficiency is the most common, though. ACTH is elevated in all three types. This is the mechanism USMLE wants for hyperplasia. That is, cortisol production is impaired in all three. So ACTH goes to increase to compensate, leading to stimulate the hyperplasia of the adrenals. The USMLE will give you a vignette of CAH, again, congenital adrenal hyperplasia, followed by which of the following is the most likely explanation for these findings? The answer should be increased ACTH secretion. Sounds weird, but is on NBME. The relevance of these conditions is that they are a cause of ambiguous genitalia and or virilization. Presentations are variable, but with questions giving vignettes in neonates, children, and adults. So the way to differentiate them comes down to the electrolytes and the blood pressure. For both 21 and 11 hydroxylase deficiencies, 17-hydroxide substrates, i.e. 17-hydroxyprogesterone and 17-hydroxyprogenolone, elevated DHEA-S, elevated androstenedione. If you see any of these up in the question, you know right away the answer is either 21 or 11 deficiency. This is because it's impossible to get a 17-hydroxy substrates in 17-hydroxylase deficiency. Fair enough. 17-hydroxy substrates DHEA-S and or androstenedione of elevated question mark. If they're not, the diagnosis would be 17-hydroxy deficiency. If they are elevated, then it's either 21 or 11. If the potassium is elevated and the blood pressure is low or normal, well, then in that case it's going to be 21 hydroxy deficiency. If the potassium is low, while the blood pressure is normal or elevated, that means that you're going to have 11 hydroxy deficiency. So again, we say the same thing down here, I guess, or something similar. 21 hydroxylase deficiency, elevated serum potassium, decreased sodium, decreased pH, low bicarb, low glucose, low or normal blood pressure, cortisol and aldosterone, as well as their precursors, are all low. 11 hydroxylase deficiency, low or normal serum potassium, elevated or normal sodium, elevated or normal pH, elevated or normal bicarb, elevated or normal glucose, elevated blood pressure. Cortisol and aldosterone are low, but their precursors, which have some effects, are high. 17-hydroxylase deficiency, low 17-hydroxy substrates, for example, 17-hydroxyprogesterone and 17-hydroxyprogenolone, low DHEA-S, low androstenedione, low serum potassium, elevated sodium, elevated pH, elevated bicarb, high aldosterone, low glucose, cortisol, and its precursor are low. What about a carcinoid tumor? Carcinoid tumor, neuroendocrine tumor of small bowel, appendix, or lung that is S100 positive and consistent with small blue cells, secretes serotonin. Presents as a flushing, tachycardia, diaphoresis, and diarrhea. Tricuspid regurgitation is common, hollow systolic murmur that increases with the inspiration due to the tricuspid lesions. Diagnosed with urinary 5-hydroxyindole acetic acid 5-HIAA. Don't confuse with serotonin syndrome, which is a drug interaction, that is to say, starting a monoamine oxidase inhibitor too soon after discontinuing an SSRI, or if a patient takes St. John wort with an SSRI. Polyglandular syndromes. All men syndromes, MEN syndromes, in Carney complex are autosomal dominant. MEN1 gene mutation, parathyroid adenoma or hyperplasia, pituitary adenoma, pancreatic adenoma. Zollinger-Ellison syndrome, gastronoma is highest yield pancreatic tumor in MEN1, will present as a recurrent peptic ulcers. I discuss this stuff in detail in the high yield gastro PDF. Parathyroid adenoma often presents with calcium urolithiasis, where they will mention flank pain or groin pain in patients with high history of ulcers. Zollinger-Ellison prolactinoma is highest yield pituitary tumor. USMLE need not to give you the full constellation of findings for the MEN syndromes. There is an MBME question floating around where the patient has a parathyroid adenoma, nothing more, and the answer is just MEN1 as a gene that's mutated. What about MEN2A? There's a RET proto-oncogene mutation, parathyroid adenoma or hyperplasia, pheochromocytoma, and medullary thyroid carcinoma. As mentioned earlier, RET mutations need not to cause the full constellation of findings. NBME questions can give an isolated medullary thyroid carcinoma in a family, and the answer is just RET. In theory, isolated parathyroid adenoma could also be RET, but with the NBME example I mentioned above, they listed the MEN1 without also listing RET. What about MEN2B? RET proto-oncogene mutation. Marfanoid body habitus, mucosal neurons, pheochromocytoma, medullary thyroid carcinoma. The oid means looks like but not so. So the patient might look like she or he has a Marfans, that is a tall and lanky, but does not, because this isn't FBN1/2 mutation. It's a RET issue. As mentioned earlier, before doing thyroidectomy for medullary thyroid carcinoma, you must check for pheochromocytoma because the stress of surgery will increase the catecholamines from the tumor and could kill the patient. By first doing urinary metanephrines, if positive, then do a CT of the abdomen. Carney complex. Hyperpigmentation, atrial and endocrine hypersecretion. The hyperpigmentation can present as a perioral melanosis, that is to say, hyperpigmentation around the lips and the mouth. This sounds similar to Peutz-Jeghers syndrome, but instead of the question focusing on hematomatous colonic polyps, the mention of cardiac tumor and other endocrine organs hypersecreting, and you're like, duh. Like, huh? Or sorry, question mark. I wonder what that could be. Well, it's Carney complex. Atrial normally shows up in adults. Cardiac rhabdomyoma normally shows up in children with tuberous sclerosis. In Carney, the question can say that atrial myxoma in a kid, so it's the only example of USMLE that breaks the rule. Endocrine hypersecretion is classically Cushing syndrome, granular hyperpigmentation of the zona fasciculata, or hyperthyroidism. The reason you likely haven't heard of Carney complex before is because students coming out of the USMLE didn't even realize this is what they saw. Well, that's an expansive section for diabetes. Fair enough. Diabetes mellitus, DM. The word diabetes means polydipsia plus polyuria, i.e. drinking a lot and peeing a lot. I see students frequently misconstrue diabetes mellitus with diabetes insipidus, since both vignettes will give patients who have increased thirst and urination. A key detail that distinguishes acute diabetes mellitus from diabetes insipidus is that DM vignettes can often mention weight loss due to an elevated catabolism. Weight loss is also seen in acute type 2, even though the patient is usually overweight. Vomiting is another high-yield finding in acute diabetes mellitus. So if vignette says elevated thirst plus elevated urination plus weight loss plus or minus vomiting, this is DM, not DI. For extensive info on the effects of diabetes on the different organ systems like cardio, renal, opthal, GIT, pregnancy, etc., go to these corresponding chapters. They probably mean GI, but go to these corresponding chapters of this document. I will keep the focus of this table on endocrine and electrolytes / acid base. Diagnosis of DM is made by measuring two fasting glucoses of greater than 126 mg/dL, any one random fasting glucose greater than 200, or an A1C of greater than 6.5%. So type 1. Absence of insulin, autoimmune mediated, no specific gene, although HLA-DR3/4 are associated. Often described as a genetic susceptibility with environmental trigger, that is to say viral infection, usually Coxsackie B, occurs almost always in children or teenagers of normal BMI. Pathogenesis is usually a combo of an antibody, anti-GAD65 or ZN-T8, and the T-cell mediated process that leads to the destruction of the beta islet in the tail of the pancreas, leading to a decrease in insulin secretion, which leads to an inability to recruit GLUT4 to cell surface of skeletal muscle and adipose tissue, causing an inability to take up glucose into cells, leading to cells are starved of energy, which causes gluconeogenesis and ketogenesis. Hyperglycemia occurs as a result of the continued glucose production by the liver, gluconeogenesis, in combination with the decrease in uptake by skeletal muscle and adipose tissue. Biopsy of pancreas shows that the inflammatory film infiltrate in acute type 1 DM in late type 1, that is to say, years later, it shows atrophy and fibrosis. It is the absence of insulin in type 1 diabetes mellitus that enables ketogenesis. In type 2 diabetes mellitus, ketones are low, not high, because insulin is present. Ketone bodies, USMLE like beta-hydroxybutyrate, are highly acidic, so will drop the blood pH, high anion gap, metabolic acidosis. Vignette will give the kid or teenager with polyuria, polydipsia, and sometimes vomiting who has severe metabolic acidosis, bicarb decline, which is due to the diabetic ketoacidosis. Breath can be fruity in odor, smell of ketones. Diabetic ketoacidosis, or DKA, will have low pH, low bicarb, low CO2. Ketone bodies are acidic, leading to causes a metabolic acidosis, decreased bicarbonate. CO2 is acidic, so we blow off to compensate. Kussmaul breathing is deep, labored breathing seen in diabetic ketoacidosis. Elevated beta hydroxybutyrate, elevated serum osmolality, elevated anion gap. Beta hydroxybutyrate is a ketone body. Since we have ketosis, ketone production, it will be increased. Serum osmolality is increased because of the serum glucose is markedly increased. Insulin isn't present to drive the glucose into cells, even though serum sodium is low, so you might think osmolality is low, similar to SIADH. The elevated glucose makes serum osmolality high. DKA is the D in mud piles, so anion gap is up. Serum sodium, so decrease in serum sodium, elevation in potassium, decrease in total body potassium, elevation in GFR. Serum sodium is decreased mostly due to the dilutional hyponatremia. As mentioned earlier, serum osmolality is high, which causes fluid retention intravascularly, leading to dilutes other serum sodium. In addition, low insulin means less glucose enters the cells. This means less ATP production. This means less cellular sodium-potassium ATPase activation. This causes sodium to not be pumped out of the cells. We describe the state of the potassium as a hyperkalemia, high serum potassium, despite a low total body potassium. The serum potassium is high for two main reasons. One, potassium proton shift. Acidosis due to ketosis causes protons in the body to exchange with potassium in the cell via the hydrogen-potassium antiporter, i.e. hydrogen ions goes into the cell, the potassium is pushed out. So it presents as hyperkalemia, even though technically the body does not has probably a lower total potassium. Two, insulin drives potassium into cells, and we don't have insulin in DKA. Insulin normally leads to upregulation of sodium-potassium ATPase, antiporter that moves the 3 sodium out for every 2 potassium in. If insulin is low, then the less potassium will be moved into the cell, causing hyperkalemia, high potassium in blood. Now, total body potassium is low because of the increased losses at the kidney. Since serum potassium is high, more potassium is filtered through the glomerulus, so more is excreted. That is to say, the kidney thinks there's too much potassium in the body since more is being filtered, so it tries to get rid of it more. However, this causes bodily depletion of potassium because the processes that causes hyperkalemia are unmitigated, so the kidney continues to excrete potassium. The GFR is increased because of the hyperinflation of secondary to hyperglycemia. That is, since serum glucose is high, more glucose is filtered through the glomerulus, which pulls water with it, causing hyperfiltration. Treatment for DKA is normal saline first, that is to say 0.9% sodium chloride prior to giving insulin. Serum potassium will drop as an insulin is given. If the question tells you patient has DKA plus shows you normal potassium, even though it's usually high, plus insulin is given, plus patient now has arrhythmia, the answer is potassium for which electrolytes is disturbed. That is to say, potassium was normal prior to giving insulin, but now it's been driven into cells and the patient's developed hypokalemia. Bicarb is always a wrong answer for low pH in DKA. Don't confuse DKA with hypoglycemic episode. The latter will be a type 1 diabetic who went out to do exercise or who was cleaning the roof of his house, who is now found unconscious. This means if insulin dose is not decreased prior to the exercise, patient can get hypoglycemia. The treatment is intramuscular glucagon, 2CK likes this, or dextrose in the water. Sometimes the USMLE can give a bit of a weird question where they say a patient is given insulin for diabetes but has prolonged hypoglycemia, plus they ask why. The answer should be deficiency of counter-regulatory glucagon. You need to know that this is advanced diabetes. The glucagon-producing alpha islet cells of the pancreas can also get messed up. I've also seen this question asked for chronic alcoholism and pancreatectomy. In both cases, if insulin is given, prolonged hypoglycemia can result from deficiency of counter-regulatory glucagon. And now that was all just type 1. Wow, okay. Now we have to talk about type 2, which is not as long actually. Let me take a brief break. Okay, let us continue. Insulin resistance, seen usually in high BMI adults, but can rarely show up in peds. 2CK form gives type 2 in a 17-year-old. So this is all type 2 right now. High BMI causes insulin resistance because adipose tissue secretes adipokines that impair insulin signaling. Insulin is high initially, hyperinsulinemia, due to beta cell hypertrophy in order to compensate for peripheral insulin resistance. Ketones are absent/low because the presence of insulin inhibits ketogenesis. The two above points are the highest yield pieces of information for USMLE. Biopsy of the pancreas initially shows beta cell hypertrophy, but years later will show amyloid deposition and cell shrinkage. Same as with type 1, hyperglycemia occurs as a result of the continued glucose production by the liver, gluconeogenesis, in combination with a decrease in uptake by the skeletal muscle and adipose tissue. Hyperosmolar glycemic state, HHS, is seen in type 2, DKA is strictly type 1 and USMLE. In HHS, again that's hyperosmolar hyperglycemic state, glucose is usually greater than 600 mg/dL. In DKA, it need not be this high. And bicarb is usually not below 20 milliequivalents per liter, and our normal range would be 22 to 28. In DKA, bicarb can be as low as it wants. I've seen 5 milliequivalents before on NBME. The USMLE vignette will give you a massive paragraph question where they mention glucose is 700 and then ask for the cause of the mental status change. The answer should be hyperosmolality or simply hyperglycemia or osmotic diuresis because causes severe dehydration. I point this out because this is particularly prevalent on 2CK NBMEs where they'll give you a 15-line junk paragraph with tons of lab values that the student spends 9 minutes reading, but meanwhile you can see the glucose is 650 and then the answer is just osmotic diuresis or hyperosmolality. Should take 2 seconds to answer. Mental status change is technically due to hyperosmolality in the ECF of the brain pulling water out of the ICF, the cells. Treat the hyperosmolar hyperglycemic state with normal saline prior to insulin. I discuss the various medications for type 2 diabetes later in this PDF. Other causes. Hereditary hemochromatosis or bronze diabetes means iron deposition in the tail of the pancreas leading to impaired fasting glucose / overt diabetes. Hyperpigmentation is due to the hemosiderin deposition. Patients can also get cardiomyopathy, infertility, and pseudo-gout. Cushing's syndrome, as discussed earlier, can cause diabetes due to the insulin resistance caused by glucocorticoids. Acromegaly, growth hormone, causes insulin resistance. Alcoholism can cause chronic pancreatitis that not only leads to exocrine pancreas burnout and steatorrhea, but can also cause diabetes due to the loss of islet cells. Pancreatectomy is self-explanatory. If you remove some of the tail of the pancreas, this can lead to diabetes. Tacrolimus is a high-yield drug that can cause diabetes. Other drugs can do this as well, but tacrolimus is a notable one for USMLE. Tacrolimus is an immunosuppressant that decreases the IL-2 synthesis and T-cell stimulation. Now we're on electrolytes. Now I'm going to take an actual short break, and you might have to skip ahead. We are on page, by the way, 369, and we want to finish up at 375. Okay, let us proceed forth. Electrolytes. Calcium, 8.4 to 10.2 milligrams per deciliter. Low calcium causes up presentation of tetany and hyperreflexia. High calcium causes down presentation of muscle flaccidity and hyporeflexia. High calcium is also associated with delirium/confusion, hypercalcemic crisis. High calcium high yield causes are sarcoidosis due to the elevated vitamin D, primary hyperparathyroidism, adenoma, hyperplasia, MEN1/MEN2A, metastatic malignancy, multiple myeloma, and thiazides cause calcium reabsorption in the distal convoluted tubule. Low calcium high yield causes are rickets/osteomalacia, decrease in vitamin D, secondary hyperparathyroidism, renal failure, post-thyroidectomy, concomitant loss of parathyroids, DeGeorge syndrome, agenesis of the third and fourth pharyngeal pouches, and loop diuretics, decrease in paracellular reabsorption, hypomagnesemia. Magnesemia can cause hypocalcemia and hypokalemia, non-responsive to supplementation, usually seen in alcoholics. Sodium 135 to 145 is what you typically see, milliequivalents per liter. Sodium derangement, high and low, causes CNS dysfunction, that is to say, confusion, stupor, or coma. Sodium can often be normal in USMLE vignettes, despite your expectation that it might be characteristically deranged. That is to say, the patient has a Conn syndrome, and yet the sodium is normal, and you're like, what? Because you expect it to be elevated. This is typical for USMLE vignettes. High sodium, high yield causes are primary hyperaldosteronism, renal artery stenosis, fibromuscular dysplasia, dehydration, diabetes insipidus. Now, low sodium high yield causes are Addison's disease, psychogenic polydipsia, and SIADH. Potassium 3.5 to 5.0 milliequivalents per liter. Potassium derangement, high and low, causes cardiac dysfunction to arrhythmia, contrast with the sodium, which causes CNS dysfunction. High potassium high yield causes are Addison's disease, renal failure, polypharmacy with agents such as potassium-sparing, diuretics, and digoxin. Low potassium high yield causes are primary hyperaldosteronism, renal artery stenosis, fibromuscular dysplasia, Cushing's disease. Chronically high glucocorticoid levels can cause hypopotassium, hypokalemia due to the distal renal secretion similar to mineralocorticoids, vomiting, diarrhea, loop diuretics, and thiazides, and hypomagnesemia. Hypomagnesemia can cause hypokalemia and hypocalcemia, non-responsive to supplementation, usually seen in alcoholics. Phosphate, 2.5 to 4.5 milligrams per deciliter. High phosphorus, high yield causes are hypoparathyroidism, secondary hyperparathyroidism, hypoparathyroidism, secondary hyperparathyroidism, renal failure, tumor lysis syndrome, and sarcoidosis, elevated vitamin D. Low phosphorus, high yield causes are primary hyperparathyroidism, rickets/osteomalacia, and refeeding syndrome. What about magnesium? Magnesium would be 1.7 to 2.2 milligrams over deciliters. Magnesium derangement causes effects similar to calcium, that is to say, low magnesium presents with an up state of hyperreflexia and increased muscle tone. High magnesium presents with a down state of hyporeflexia and muscle flaccidity. Low magnesium high yield causes alcoholism, decreased dietary intake, leads to hypocalcemia and hypokalemia, non-response to supplementation. What about acid and base? If you want to practice with acid/base USMLE questions and or are confused by the certain things I list in this table, go through my high yield arrow PDF. I discuss this stuff in comprehensive detail. Normal blood pH is 7.35 to 7.45. Normal blood bicarb is 22 to 28 milliequivalents per liter. Normal PCO2 would be 33 to 34. Metabolic acidosis. Low pH caused by low bicarb. PCO2 will go down to compensate CO2 was acidic. High anion gap metabolic acidosis. Mud piles is the mnemonic for high anion gap metabolic acidosis, methanol, uremia, renal failure, DKA, fenformin, weird drug you don't need to know to worry about, iron tablets, isoniazid, lactic acidosis, ethylene glycol, antifreeze, salicylates aspirin. If the patient has metabolic acidosis and the anion gap is normal in the question, you can eliminate the mud piles answer and choose an answer like the renal tubular acidosis RTA. Anion gap is calculated as a sodium bicarb plus chloride. So sodium minus parentheses bicarb plus chlorine. Anion gap of 8 to 12 is normal, so 13 or greater is high. I specifically write 13 or greater because there is an MBME question where the anion gap comes out to 12 and they want renal tubular acidosis. I talk in detail in the high yield renal PDF about RTA. Normal anion gap metabolic acidosis, diarrhea, renal tubular acidosis, adrenal insufficiency, and CAH, which is congenital adrenal hyperplasia, 21 deficiency, are the most important. Metabolic alkalosis. High pH caused by a high bicarb, PCO2 will go up to compensate. Conn syndrome, renal artery stenosis, fibromuscular dysplasia, vomiting, loops, and thiazides promotes RAS activation due to the volume depletion. Respiratory acidosis, low pH caused by CO2, bicarb goes up if chronic to compensate, bicarb is basic. Acute normal bicarb, hypoventilation due to opioids, benzos, barbiturates, chronic high bicarb, COPD, obstructive sleep apnea, obesity, ankylosing spondylitis, severe kyphoscoliosis. Respiratory alkalosis, high pH caused by low CO2, bicarb will go down if chronic to compensate. Acute normal bicarb, asthma attack, panic attack, most pulmonary emboli, altitude sickness, first day at the high altitude. Chronic for low bicarb would be living at a high altitude. Or pregnancy, progesterone upregulates the respiratory center. So basically, you're breathing more than you typically would. It should be noted that the primary metabolic acid-based derangements are compensated for instantly by changes in respiration. That is to say, it's easy to retain or breathe off carbon dioxide merely by changing respiratory rate, whereas primary respiratory derangements are compensated for slowly because it takes a time for the kidney to actually alter its bicarb excretion. So the actual compensation time is different between the metabolic renal system versus the respiratory system. Winter formula is used to calculate predicted PCO2 based on any changes in bicarb, where the predicted PCO2 equals 1.5 times bicarb plus 8 plus or minus 2. For example, if the patient has a DKA of bicarb of 14 milliequivalents over liters, we expect a PCO2 to be 27 to 31. If PCO2 is lower than 27, then the patient has a concurrent respiratory alkalosis. If it is higher than 31, the patient has a concurrent respiratory acidosis. So in those cases, we would say that it can't be just that. It has to be more than one thing going on at the same time, which is possible, certainly for questions on exams. Although I'm not sure how much acid-based stuff there's going to be on step 2. It might be some. Salicylate toxicity. Diagnosis of salicylate aspirin toxicity, tinnitus, ear ringing, is the most common first symptom. This patient has a mixed metabolic acidosis respiratory alkalosis, that is to say, both a metabolic acidosis and a respiratory alkalosis at the same time. Again, metabolic acidosis, but also respiratory alkalosis. So aspirin initially causes an isolated respiratory alkalosis within the first 20 minutes due to the direct upregulation of respiratory centers in the brain. However, aspirin itself is an acid, salicylic acid, so it will ultimately cause a metabolic acidosis that wins over the respiratory alkalosis, that is to say, pH will ultimately go low. And keep in mind, it's not a compensation. Neither of these are compensation mechanisms of the other. They are happening simultaneously from the same drug. Makes sense? Not compensatory. They're overlapping disorders. Anion gap is high. Salicylates are in the S in mud piles. So sodium and potassium are normal in salicylate toxicity. I've seen these arrows listed before, which causes students confusion, but they are unchanged. Sometimes the question will give you a numerical values where you need to calculate the anion gap, that is to say sodium minus bicarb, parentheses bicarb plus chlorine ions. The value must be 13 or greater since it's one of the mud piles. Normal range should be 8 to 12. In summary, once again, for aspirin, first 20 minutes, acute respiratory alkalosis, elevated pH, normal bicarb, low CO2. After 20 minutes, mixed metabolic acidosis, respiratory alkalosis, low pH, low bicarb, low CO2, elevated anion gap. The low bicarbonate we see after 20 minutes is not compensation. Yeah, exactly, as I said. It coincidentally goes low, as we'd expect for renal compensation in their setting of a respiratory alkalosis. But remember that the kidney cannot induce this change until a minimum of 12 to 24 hours later. The reason bicarb is low after 20 minutes is because aspirin level itself is an acid that is causing a metabolic acidosis and driving the bicarb low. A 2CK level point is that sodium and chloride can be abnormal insofar as the bicarb is low and the anion gap is high. Potassium must be always normal. You might get an aspirin question where you're forced to choose between either an up or down arrow for chloride, and you have to say, I haven't heard of that before. I thought it would be just normal. But if you're forced to choose, clearly you'd go for the answer where the chloride is low, since the anion gap is calculated as sodium minus bicarb plus chloride. So, or parentheses bicarb plus chloride is in parentheses, and you minus all of that from sodium. So, if you had to choose low for chloride. And a low chloride would make the anion gap higher than the answer choice with a high chloride. Renal failure key disturbances. As discussed earlier, renal failure causes secondary hyperparathyroidism, where we have a decreased calcium, elevated phosphate, elevated PTH, and a decreased 125D3. However, it is also past level, that in renal failure we also have elevated potassium, decreased bicarb, decreased pH, elevated anion gap, U in mud piles, uremia equals renal failure, with sodium variable. The kidney normally secretes potassium distally in the cortical collecting duct under the action of aldosterone. So if the kidney is messed up, we can't do that, so potassium is elevated. Likewise, we normally have a bicarb reabsorbed in the PCT and the hydrogen ions secreted in the cortical collecting duct. So if we can't do either of those things, blood bicarb and pH should be low. So let's see our timing right now. We are technically at 1:08 for how far we're in, and counting, of course, some seconds they're in. We're on page 371, going over to 372. So we're wrapping things up, I think. High-yield pulmonary acids/base findings. Acute asthma attack and pulmonary embolism. Decrease in PCO2, no change in bicarb, elevated pH. The key here is that these conditions cause acute respiratory alkalosis, not acidosis, as I mentioned in the above table. Students normally mess this up and think that PCO2 is high. PCO2 only goes up if the patient becomes tired as an asthma attack prolongs. But initially, both of these conditions, we have a low PCO2. Oh my gosh, not high. Bicarb is unchanged because it takes a minimum of 12 to 24 hours for bicarb excretion to be sufficiently modulated by the kidney. Tangentially, metabolic acid disturbances, acid-base disturbances, are instantly compensated for by changes in PCO2 by simply breathing more or less. Patients with COPD and obstructive sleep apnea are chronic CO2 retainers, where we have a elevated PCO2, elevated bicarb, decreased pH, bicarb goes up to compensate. What about miscellaneous high-yield acid base? Vomiting. Low serum potassium, low chloride, elevated bicarb, elevated CO2, elevated pH. Very high yield to know that the vomiting causes a hypokalemic, hypochloremic metabolic alkalosis. Vomitus contains lots of potassium, chloride, and protons. In addition, volume depletion can promote a distal renal losses of potassium and hydrogen secondary to RAS upregulation. Carbon dioxide is acidic, so we want to retain it to compensate. Loop thiazide diuretic abuse. Low serum potassium, low chlorine ions, chloride ions. So low serum potassium, low chloride, high bicarb, high CO2, high pH. Furosemide is a loop diuretic. It will block the apical 2-chloride potassium sodium symporter in the thick ascending limb. Since water follows ions and ions reabsorption is impaired, increased diuresis urination occurs. Volume loss causes upregulation of RAS and distal secretion of protons under the control of aldosterone, leading to the metabolic alkalosis. This is referred to as contraction alkalosis, where the volume contraction induced by diuretics promotes metabolic alkalosis. In addition, additional distal secretion of potassium occurs. Thiazide diuretics will also follow this arrow pattern. They block the sodium chloride symporter on the apical membrane of the early DCT, leading to the volume depletion and the elevation of RAS, thereby elevating the hydrogen and the potassium secretion distally. CO2 is acidic and retained because it compensates for our metabolic alkalosis. It should be noted that these arrows are the same as for vomiting. Diarrhea. Low serum potassium, elevated chloride, decreased bicarb, decreased pH, decreased CO2, and a normal anion gap. Stool is rich in potassium and bicarb. Diarrhea and laxative abuse can cause a normal anion gap metabolic acidosis. Since CO2 is acidic, we blow it off to compensate. Serum chloride is high due to the cellular shifts. Anion gap is normal because diarrhea is not part of mud piles. It's good to know. So it causes a low pH. So remember, diarrhea lowers your pH while vomiting elevates your pH, because vomiting is removing all this acid while diarrhea removes base, basically. Laxative abuse is scored with a similar camp. So low serum potassium, elevated chloride, low bicarb, low CO2, low pH, normal anion gap. So stool is rich in potassium and bicarb. Diarrhea and laxative abuse can cause a normal anion gap metabolic acidosis. And CO2 is acidic, we blow it off to compensate. Serum chloride is high due to cellular shifts. So basically the same description. Barring these just added, they have a little bit less, they have more information in diarrhea, just a little bit more about the anion gap stuff. Okay, now we're still on page 372. We're talking about endocrine pharm for IM, keeping things high yield. Metformin. So this is like the wrap-up section. This is the farm stuff they have in these chapters, apparently. At least for some, if not all. Metformin, mechanism of action, elevated glycolysis plus a decline in gluconeogenesis. Only used for type 2 diabetes mellitus. Causes lactic acidosis. Discontinue if bicarb is low means a lactic acidosis. Discontinue or don't commence if creatinine is 1.5 or greater, as reduced renal function causes an increase in risk of lactic acidosis. Choose insulin over metformin for regulation of glycemic control in pregnancy / intrapartum, as it allows for optimal fine-tuning / control of glucose. USMLE can give you a patient on metformin who had a CT with contrast plus gets high creatinine as a result. Plus, they ask you what you would have prevented the increase in the creatinine prior to the CT. The answer should be infusion of a 0.9% saline or adequate intravenous hydration. The wrong answer would be discontinuation of metformin. This one is a little tricky, where we need to know that the adequate saline hydration is the number one way to prevent constant contrast nephropathy. There is an elevated risk of lactic acidosis due to the metformin in patients who have renal insufficiency, but metformin itself does not cause renal insufficiency. In other words, elevated creatinine is a reason to stop metformin, but an increase of creatinine doesn't result from metformin itself. Insulin. USMLE doesn't care about what you know about all the different insulin types and their durations of action. What USMLE might do on 2CK is give your patient with diabetes who wakes up with severe hyperglycemia, plus ask you what needs to be done. The answer is decrease, not increase. Oh my gosh. I'm like the Kids Bop version of whatever this is, I guess. Dose of evening intermediate acting insulin. This is called the Somogii phenomenon, or Somogii, I don't know. SOMOGYI phenomenon, where it appears as although because morning glucose is elevated, this means evening/night insulin is insufficient. But it's actually the opposite, where the evening or night dose is too high, which pushes the patient into overnight hypoglycemia, causing a compensatory sympathetic response that results in a robust rebound hyperglycemia by morning. The other question they will give is a patient with a type 2 diabetes mellitus who is already on metformin plus glyburide who has uncontrolled A1C at 12% and gives you either low bicarb or high creatinine, which leads to they ask you what needs to be done, and the answer should be discontinue metformin and glyburide and commence intermediate acting insulin. I've made YouTube clips on this question and I have talked about this many times as it gets asked in our Telegram group. Wow, this is just going into all of his other stuff. Okay. Group probably once a month. The point is that, one, if a patient has low bicarb while on metformin, this means lactic acidosis due to metformin. So, you must choose the answer choice where the metformin is discontinued. And two, a patient who has a creatinine 1.5 or greater needs to be off metformin. I've seen max on 1.4. I've seen max 1.4 on NBME where the metformin is acceptable, since the renal insufficiency is a risk factor for lactic acidosis due to metformin. Sulfonylureas. Glyburide, glipizide, glibaclamide. Insulin secretagogues, that is to say, increase insulin secretion by blocking the ATP-gated potassium channel on the beta islet cells without the need for ATP. Glyburide and glipizide tend to be the ones that show up repeatedly on NBME. I don't think I've ever seen other sulfonylureas on NBME for that matter. Glibaclamide is known for causing severe hypoglycemia. You could be aware of this in theory. Metaglitinides, which is example would be repaglinide, similar to sulfonylureas, these increase insulin secretion by blocking the ATP-gated potassium channel on the beta islet cells without the need for ATP. GLP-1 analogs, liraglutide, semaglutide, Ozempic. Glucagon-like peptide 1 stimulates insulin release. DPP-4 inhibitors, sitagliptin. DPP-4 is an enzyme that breaks down GLP-1, so if we inhibit the DPP-4, GLP-1 is elevated, therefore, increased insulin release from the pancreas. Thiazolidinediones, pioglitazone, elevated insulin sensitivity at tissues by stimulating the PPAR gamma can cause liver toxicity. Alpha-glucosidase inhibitors, acarbose, miglitol, decrease in glucose absorption in a small bowel can cause diarrhea. SGLT2 inhibitors, dapagliflozin, decrease glucose reabsorption in PCT of the kidney, can increase the risk of candidal infections. Okay, fair to know. Amylin analogs. Pramlintide. Amylin is a hormone that is co-secreted with the insulin from beta cells that suppresses glucagon secretion, slows gastric emptying, and promotes satiety, thereby, preventing a rapid increase in the postprandial blood glucose. What about propylthiouracil and methimazole? Well, PTU or propylthiouracil and methimazole are both used for Graves' disease. Both inhibit thyroperoxidase. PTU has an additional MOA inhibiting the 5-deiodinase. Both PTU and methimazole can cause neutropenia, agranulocytosis. You need to know this often presents as mouth ulcers and USMLE. For example, they'll say the patient was recently treated with hospital for thyroid storm, but now has mouth ulcers and fever. The answer should be drug adverse effect or drug-induced neutropenia. Propranolol is used for the tachycardia in hyperthyroidism. Beta blockade inhibits the 5-deiodinase. Steroids are used for exophthalmos. Methimazole is teratogenic in first trimester. Okay, good to know. Demeclocycline shows up as a treatment for SIADH on NBME, tetracycline antibiotic that causes nephrogenic DI as an adverse effect, but this is actually a good thing if we want to treat SIADH. Let's just treat one, because you're counteracting the effects. So he says, let's just treat one problem by causing another problem and see how somehow they cancel out. Well, in that case, it's not a problem. You don't call that a problem. It's called like saying, oh, I accidentally drove to the wrong location. Now I'm 5 miles south of where I need to be. Or just drive 5 miles north. Oh, that's another problem? No, it's a solution, right? Whatever. Desmopressin. Vasopressin ADH analog used as a treatment for central DI. It's also called, I think, DDAVP for reference. Also used after fluid restriction in DI cases for the differentiating central form nephrogenic. Octreotide, somatostatin analog used for acromegaly and esophageal varices. Cinacalcet increases sensitivity of calcium-sensing receptors on parathyroid glands. helps to suppress PTH and secondary hyperparathyroidism. And that is the end of the section that we have here for the endocrinology. So if you liked this video, feel free to like and subscribe and do all things of that manner in accord. Hopefully you found this video useful and perhaps of good utility in terms of learning the content described therein. Hopefully you have a great rest of your day. Thank you.